Good morning. My name is Vishad Nabili. Welcome today. It gives me a great joy to be back here at our webinars with UCLA. I'd like to first thank the audience for coming today, UCLA Health for providing this opportunity, and our entire phenomenal media team. The title for today's talk is Rhinoplasty, a safe systematic approach to nasal surgery. Like I mentioned my name, I'm an associate professor and the residency program director with the Division of Facial Plastic and Reconstructive Surgery and our UCLA Head and Neck Surgery Department. There's no disclosures I have today. Briefly, as I did our last webinar, I'd like to first talk about our training. It's quite important that all of our physicians at UCLA, both in the plastic surgery department as well as in the head and neck surgery department, Division of Facial Plastic Surgery, we have a lot of expertise, and that expertise comes from our board certification and training. I'm dual certified both with the American Board of Otolaryngology Head and Neck Surgery as well as the American Board of Facial Plastic and Reconstructive Surgery. I think for the audience out there and potential patients, it's very important to make sure that your physicians who take care of you are trained and certified by their board of medical specialties. So I was asked to do this talk by many of my own patients as well as my colleagues, just to really educate ourselves on rhinoplasty. The term is used loosely, and some of the most common questions throughout the years that I hear from patients, even family members, are some of these, and we'll get back to these at the end, but I just want to briefly go about them. Is this a nose job? Is this a septoplasty? Is this cosmetic? Will it fix my breathing? Will my nose look straight, doc? Will this hump on the nose go away? And do I need anesthesia? And last but not least, which has come up recently and I added this, what is a liquid rhinoplasty? So keep these questions in mind. We'll go through a systematic talk and we'll talk about why I entitled this a safe systematic approach. Let's start off with the term rhinoplasty. What does it mean? By definition, it means nose molding, nose forming. It's often referred to as a nose job, but most people think rhinoplasty is cosmetic, and I just really want to debunk that myth. Rhinoplasty is the procedure. The indications are what's important. Is it functional, reconstruction? Is it cosmetic, aesthetic, or can it be both? And sometimes it does involve the septum itself, and we'll talk about that as well, and that becomes the term septorhinoplasty. So why did I entitle this talk A Safe Systematic Approach? Being at UCLA, if you looked at our previous webinars, we really try to educate the audience on an evidence-based approach, being safe, systematic. But what's really important when we're dealing with nasal surgery or a rhinoplasty is to decide, what are we thinking about here? Our nose is a functioning entity. It lets us breathe, lets us smell. So these things are important. In fact, it filters, warms, moistens the air, and we know that because the slight congestion we get, we're miserable. And so those things are really important to us besides just how it looks, and how it functions is really important. So a safe, systematic approach will get us there. If we're not safe, guess what happens? You have a small, pinched, deformed nose, you can't breathe, you can't smell, and potentially you may not even be able to fight off some infections that can transpire and be filtered through your nose. I truly think rhinoplasty is an art. I say this because there's three pillars of balance that we have to achieve with this surgery, and other types of surgeries may not be. And these are, there's form, how it appears, how it holds itself, the anatomy, how it functions, as we just talked about, the ability to breathe. And the last dimension, which is probably the most challenging, is the perception of the final result. And we'll talk about that. I segue just to bring up my background and to kind of tell you why I do rhinoplasties and why I'm excited about this area. My training is in these areas: microvascular tissue transplantation. The first 5 years of my 10 years of training did a lot of free flap tissues, and that was taking tissues from other parts of our body, transplanting it with the arteries and the veins, and connecting it and reconstructing someone's face. I do a lot of skin cancer reconstruction, trauma-related reconstructive surgery, and most recently I've been fortunate to be a member of our face transplant team, where in essence we've taken apart the entire face and put it all back together to understand the anatomy. And now 50% of my practice is really dedicated to cosmetic surgery or aesthetic surgery, and I think the balance is critical. That's why I think facial plastic and reconstructive surgery are one and the same. You have to achieve beauty and balance with everything we do. Why did I bring that previous slide? Because it segues into this next slide. In all the things that I do, I by far think that rhinoplasty is the most complex surgery. And the reason is it goes back to the 3 pillars and the things we have to balance. Not only does form and function important, but form doesn't always follow function. And for example, the nose may look great at the end, but a few millimeters inside could be a little off and you don't breathe well. That's a problem. And then last but not least, it's really important, and this has to do with the entire consultation you have with your physician, discussing the surgery, to really understand one's perception of how he or she feels about the appearance of the nose. The nose can be perfect at the end in someone else's eyes, but the patient's perception of the end result's the most important. And having us as physicians, as plastic surgeons, try to understand that, that's the most challenging part. And that's what I really want to focus on when I meet with you to discuss rhinoplasty. Our systematic approach today is also as part of our lecture. We're going to do a systematic approach in 3 parts. The first one is a deviated septum surgery, usually known as a septoplasty, but I put it today as rhinoplasty, and I'll explain why shortly. Part 2 is functional rhinoplasty, and part 3 will conclude with cosmetic rhinoplasty. So for part 1, rhinoplasty for the deviated nasal septum. If you look at this caricature of a face, the nose looks straight, and yet maybe the septum is straight or it may not be. What is appearing on the outside in someone who may have a deviated septum may be completely normal, as is demonstrated here. So the external appearance in someone who comes to us with a deviated septum, nasal blockage, the outside may look fine. And lo and behold, the septum is in fact deviated. The most common causes when someone says, well, doc, I don't really recall ever having an accident, never falling, never breaking my nose. It may happen when you don't remember and you were just born, and as children pass through the birth canal, it's in fact pushing on the nose, and that may cause a deviation with no history of trauma. But the more common scenario is, as demonstrated here, a nosebleed. And how you kind of know you broke your nose, possibly, is you have a nosebleed. If you fell, you hit your nose, but you didn't bleed, chances of causing a broken nose is much less. This slide is important because when we look at the nose from the side view, where is the septum? So here's the outside of the nose as we see here. Here is just under the skin, we have the cartilages, but that's the side of the nose. The septum is right in the middle, separating the left and the right from either side. And what it really has is a cartilage portion right here, a bony portion right here, and then the closest part to the tip of the nose may in fact have no cartilage and it's soft. But all together it serves as a structure that holds our nose. And what's also important about this slide is if you look back here, right up here, our brain sits right atop our nose. So rhinoplasty and septoplasty and moving the nose around, it's really important how aggressive and how minimally traumatic we try to balance that, because the brain sits very nearby. And also if you look here, that's also important, you see your teeth, but you also see the roof of your mouth, the palate. Why is that important? Sometimes in rhinoplasty or septal surgery, you may notice some numbness, and we'll talk about that. Well, there's nerves that go from our palate all the way up to our nose, so if we have a deviation of our septum and we fix that, it may temporarily cause problems of sensation changes in our palate. So this is just an introductory as to a septoplasty. But again, if you see, the title of my talk is Rhinoplasty for the Deviated Nasal Septum, and I'll segue into why that's important. A standard septoplasty done by many surgeons, a lot of them being also general otolaryngologists, ear, nose, and throat doctors, plastic surgeons, facial plastic surgeons. Oftentimes, they treat a portion of the septum that's deviated, as demonstrated right here. This is again an inside view of the nose. This bluish colored area is the entire cartilage, not bone. And we demonstrate usually when a septoplasty is done, this piece that's removed is this area that may be deviated, as demonstrated here. This is looking inside the nose, showing how we can approach the septum without actually having to make any scars or incisions on the outside. But the reason this slide's important is, what if the septum is deviated here? Why did we save this? Because it's holding our nose together. This is termed an L strut, and if you see, it's the shape of an L. So oftentimes, when people do a septoplasty, we preserve intentionally for support this part of the cartilage. But what if that part's deviated? It's still a deviated septum. It still needs a septoplasty, but maybe more challenging, hence the term rhinoplasty. So I often get patients who have had a septoplasty, and you look inside their nose, and that portion back here is completely straightened by the outside doctors. They did a phenomenal job. But the patient says, "Doc, I'm still having problems." Because lo and behold, when you look at the actual nose, that front part is still deviated. And the challenge is, if you manipulate that area and you don't have the expertise for how to fix this area correctly, and you're not safe and systematic, the tip of the nose can drop. And so oftentimes I get to do a rhinoplasty for a revision septoplasty or a complicated septum that's deviated much more in front, and that's called the deviated caudal septum. As demonstrated here, this is that location we talked about. It's that front part. The back may not even be deviated. So how do we fix this? So here's a quick preoperative patient, same patient, immediately after surgery and a week after surgery. And you can see the difference. But what we had to do is, this was a severe deviation in the front part of the nose, and we had to do a rhinoplasty approach. Open the nose, mold it, shape it, move things around. And as you see, a week after surgery, that scar is already being more and more minimally visible. A year follow-up for another patient, similar problem, you don't see the scar. Problem solved, patient breathes well, the anatomy's open, safe, systematic. So how do we do this? Well, for one thing is, some of my colleagues and mentors have used this analogy, and it makes a lot of sense. Oftentimes when this septum, if you will, is so deviated and we see it along the front part of the nose, try to think of that septal cartilage or the septum maybe a little bit large for the nose that it's in. And so sometimes you have to actually remove some of the cartilage, this little area right here that's red, that's not only deviated to one side, remove part of it, swing it over to the bone that it's supposed to sit on, and then suture it down. But this is all occurring in the front of the nose. And trying to avoid a scar is difficult when it's so far forward. So it's important to balance putting a scar that's going to disappear in a year and making sure you do the right thing that one time, create a very safe structure for the tip of the nose. Can we do it scarless? Of course. And I always start these operations a scarless approach if it's possible. Here's another example of someone who has a patient of mine with a deviated caudal septum, but it's not as forward as the other patient. So we can go through inside the nose, do the same exact maneuvers you saw in this picture here, and yet close everything, provide a safe, systematic, open approach to the airway, and yet no scars at all. So every patient's different, every case is different, but the understanding and the fundamentals of rhinoplasty to achieve this are really important. Part 2, functional rhinoplasty. So remember, the term rhinoplasty is used interchangeably, but we're adding the descriptive term of this is functional. Function is the priority, and we'll talk about what that function is. And the form should follow the function, and that's our goal. If we fix the function, the form will follow. The most common scenario that's a quick surgery, but I treat it very cautiously and I treat it with a lot of respect, is someone who has had trauma to their nose acutely, within 2 weeks. An elbow, car accident, they ran into a cupboard, someone threw a ball playing with their child, and lo and behold, they twisted their nose. They look in the mirror, the nose looks twisted to one side, they recall bleeding from the nose, and now they can't breathe. The standard crooked nose. So what do we do? So we look at the external appearance and we know this is not correct. The patient agrees it's not correct. Same patient, just slightly different views. And it's twisted. Maybe the septum's twisted too. What we do in that acute scenario, if you come to us within usually 24 hours to 2 weeks, if you come in within the first couple of days, about 48 hours or so, I like to wait, let the swelling come down. But usually within 2 weeks is when the bones have tried to start healing, but they're still movable. And we do what's called a closed nasal reduction. If it's caught early within the first 24 hours, ideally in the first 12 hours in the emergency room, sometimes our plastic surgery colleagues can be called over and we can potentially do this in that immediate setting with local anesthetic. Oftentimes I prefer to do it in the operating room. And the reason is I try to get the best result at that time. It's an attempted correction, mobilizing the bones manually to get them back to where they were. It says here roughly 50% success rate at straightening the nose. That's a pretty low number, but it's the truth. I think the reality of it is the accident that happened, it may have broken more than one bone in different angles and directions because we don't know. The skin is covering the area, so we don't know exactly what broke in what way. We're trying to make it look right. And so in this closed environment where we're literally not being able to open the nose itself surgically, we're moving it over. I think if you do it correctly within 2 weeks in the operating room, planned out, you can probably crack that up there to about 80 to 90% success rate. But I say this because sometimes the nose has memory. You think you straighten the nose, and then within the next few months, the nose may deviate back to where that initial trauma was. And we'll talk how we fix that with a formal open rhinoplasty. And that's what that says there. So then patients come to me sometimes and say, Doc, Dr. Nabili, this was done 3 weeks ago. And so I say, okay, well, it's really risky if we go early now because the bones have healed. We may not be able to manipulate them well. So we need to wait about 3 to 6 months. Years ago, the thinking was 6 months, but more and more recently we're looking at maybe even earlier to go in and then do a definitive correction of the nose to improve the function. So here's that same patient, pre-post-op. Success, long-term, went great, and it does work for the acute fracture. It is a rhinoplasty. It's just not as involved. It can take 15 to 20 minutes, but it's really helpful if we can get this done in the 2-week period. So a more defined approach to functional rhinoplasty is the goal is to improve that nasal breathing that we talked about. Patients present with obstruction. They can't breathe through their nose. They're always found to have some anatomic problem if you're going to go in and do a functional rhinoplasty. Most often the problem is dealing with the valves. Well, what are the valves? We'll talk about that. But there's two major ones we need to think about. Internal nasal valve, external nasal valve, and then there's additional anatomic problems that go into functional rhinoplasty that I'll talk about. One we already talked about, and that was the deviated septum. Inferior turbinate hypertrophy, septal perforation, and a saddle nose deformity. The nasal valves. So this is taken from a patient of mine, but there's two major valves, the external nasal valve and the internal nasal valve. And from the drawings here, the external nasal valve, the best way to think about it is the opening to our nose, simply put. But let's define the anatomy as well for you. So we have our cartilages. These are the lower lateral cartilages. There's a medial portion and a lateral portion. It's the opening to our nose. So this is the drawing. This is a patient of mine. The external nasal valve has the cartilage here, the medial crura, and the lateral crura. Internal nasal valve. So if you look at this same patient, what we've done is we just scaled back a little bit. And if you take the nose and you divide it into thirds, the proximal third up high, the middle third, and the distal third, we're right at that junction where the arrow is pointing to, where the middle third and the distal third. And that's where our internal valve is. So if you were to look right here on our external valve, which is the opening to our nose, and if you were to imagine walking through the nasal passages, the next step would be what's called the internal valve, right where that arrow is. And what we see here is our nasal septum, and then we have our upper lateral cartilages. Down here, they're called the lower lateral cartilages, demonstrated here, and then up here is the upper lateral cartilages, as demonstrated in this image of our patient. There's an angle that forms there, and if that angle is narrow, it causes internal nasal valve narrowing, problems breathing. But there's another facet to this that's quite important, and that's the turbinate, this erectile tissue that we have inside our nose. And the best analogy is if you exercise or you have allergies or you get a cold and you lie on one side for a little bit, you feel like, well, I can breathe through the other side. And then you tilt your head to the other side and you can feel, I can breathe on this side now. Well, that actually happens throughout the day. The tissues increase and decrease in size, the turbinates, and they allow you to breathe. But sometimes there may be pathology where you have an allergy or a congestion that's chronic. And that turbinate can actually be large enough where it can block the airway, and we'll talk about that shortly. Are there any tests that we need to do when you come visit us to discuss rhinoplasty from a functional standpoint? Of course, and insurance companies actually require this as well. But it's important, I think, for our patients to know the terms, because if they see their note and they say, gosh, what is a caudal maneuver and what's a modified caudal? So hopefully this slide will demonstrate. The best analogy that you could think about are those breathe right strips that work great. And so the caudal maneuver is literally placing your finger on your cheeks near the side of your nose and pulling it to the side. And that may, in fact, open up our internal and our external nasal valve and give us an indication that maybe there is some obstruction if that helps. The problem with this study is, I will tell you, this test, almost all of us, it helps our breathing, even if we're not obstructed at rest. So it's really, you're obstructed on that side, and it actually allows you to breathe is the best way to look at it. But if it makes your breathing better, it will work probably in most of us. And the modified caudal is a little bit more defined, where you place either a Q-tip or a little curette gently inside the nose and just push that valve out. And where that's pushing in this picture right here is right where this internal valve area is in my patient here as well as in this picture. So, caudal maneuver, modified caudal. There's also dynamics, and you can look at the patient. This is a patient right before surgery. We have them breathe, and where these dotted lines are the areas of collapse, especially so on one side. Again, same patient that we saw over here. We know it looks a little bit pinched here. Fast forward to this slide. We have them at rest. That means just relaxing, then have them breathe in, and it pinches right there. I mark that area because if I need to put something there like a graft, I know exactly where the problem is. So the types of rhinoplasty is really important. There's two terms you need to know, open and closed. Technically, we like the term endonasal. That means from inside the nose, no scars, and then open approach as well. Both are used successfully, and we'll talk about that as well. The closed or endonasal incisions are inside the nose, and then the open involves an incision on the bottom of the nose at the what's called the columella, and I'll show a picture of that. So this is called the open rhinoplasty scar, and this is a patient 4 months after, and this is right before, where we mark where our approach would be. And again, the scar within a year is almost barely discernible. Let me give an example of a patient. So this is a patient who came to us with nasal breathing problems, and we did a functional rhinoplasty. This is exactly what I do before the surgery. Plan this out. And so I'm just demonstrating it for you so you understand as well. What is our approach? Well, for this patient, we're going to do an endonasal closed or scarless approach. We have to repair the internal nasal valve with something called a spreader graft. We have to repair the external nasal valve with a Batten graft. We have to also repair the deviated septum, and then we have to bring those cartilages in the middle of the nose back together as well. And then last but not least, the turbinates were large as well, and we need to fix those. So same patient, before surgery, I plan everything by drawing. I confirm my drawings after I complete the surgery, so we know, what did we do? We thought we were going to do these things. Did we do it? And we make sure that's part of your record. So same patient, before surgery, we had an external valve problem. This was narrow, it was collapsing, and the medial crura, these little cartilages of our external valve, needed to be brought back together. So in this drawing, I thought I'm going to put cartilage in those areas, which I did. Those are called Batten grafts to repair the external nasal valve. Postoperatively, the opening is much more open. The valves are now fixed externally with the cartilage. Same patient. These two are the same patients. You saw the narrowing in this area here. We needed to put a spreader graft. We planned to do both spreader grafts, but in actuality, we ended up only needing it on one side to fix that opening and make that area wider. Same patient, post-surgery, pre-surgery, functional, closed, endonasal rhinoplasty. The inferior turbinates, what do we do? So when we look in the nose, and you can look at home and see, the turbinates are that first little structure that is not in the middle of the nose, which was the septum, but to the side. And usually you don't see it. But when you catch a cold, it gets boggy, you have discharge. But if they're large, we actually will shrink this down. It's called a inferior turbinate reduction. And there's many methods, and they're all successful. When you meet with your surgeon, they'll discuss what works best in their hands. And that's the most important. Your surgeon giving you the best result with what they are very comfortable doing to give you the best result. A couple of slides. I won't get into the details of this, but I want to be complete. When it comes to functional rhinoplasty, septal perforation is something else that needs to have a rhinoplasty approach. And that's when someone's had either a previous septoplasty, they had a deviated septum before, and a complication of that surgery afterwards was a hole was created in that septum as it healed. It can happen, even in the best of surgical hands, but it can also happen if you have trauma and some blood collects in there and it goes unnoticed and it's not drained. The blood can collect, it can cause pressure on the cartilage, get an infection, and this tissue, the lining called the mucosa, which is like a skin lining inside the nose, creates a hole, and you end up having a hole. How does that manifest itself? How do you know? Patients will come and say, Dr. Nabili, I don't breathe well, but when you look inside my nose, it looks wide open. And I look inside and I realize they have a perforation, and they may have had a septoplasty before. It may have been from illicit drug use or something inhalational. Many factors, or trauma. And what happens is the flow of air that normally goes to the back of our throat has a lot of turbulence here. It doesn't have a nice passageway. So even though inside the nose looks wide open, it's turbulent airflow. It can't pass. And so the correction for this is actually complicated, and you need reconstructive expertise to do this. And one of our former fellows wrote a great paper by Dr. Jordan Sand, and it's in the Plastic and Reconstructive Surgery Journal from 2015, but describes a common method that we all incorporate with reconstructive expertise, and that is to elevate these flaps and shift them forward. And so again, a rhinoplasty approach can be needed for that. A saddle nose. Someone comes in and says, Dr. Nabili, my nose has dropped. And what happened? Well, I had a rhinoplasty years ago, or I had a septoplasty years ago. And what happened in those scenarios, if we can just briefly go back, maybe the complication was the cartilage, this L strut that we tried to preserve, or the doctors in the past tried to do a septoplasty, this area was not stable and it was too thin. It collapsed. Or there's a perforation and this became weak. So what happens is the bridge of the nose collapses and you get what's called a saddle deformity. I won't go into details too much about this, but this involves reconstructive expertise. It's not a standard run-of-the-mill simple rhinoplasty. For this patient of mine, came to me, saddle nose, we needed good tissue. We needed hardy tissue. The cartilage was already gone because the septoplasty had been done and this was a complication, and they were referred to me to see if we can help them. So the two choices are bone. Usually we can get it from the skull. That's an option. Usually we reserve that for collapses up here where there is normally bone. But if you recall, this part of our nose that's missing here under the skin is cartilage. So a good place is our rib. And usually our 6th rib, 7th, 8th, 9th, those ribs have cartilage components. And so we took the cartilage. This is a post-op patient, about 3 months, same patient, pre and post, quite happy, and the results were successful. And we could discuss this if you come in and need a rib reconstruction. Breaking the bones. I get this question a lot. You know, the controversies about how do you break the bones. And this is breaking the bones for rhinoplasty. Remember, we're molding things. We're modifying the cartilage, but we're also modifying the bone. And so there's different approaches. But simply put, as a systematic approach to rhinoplasty, I believe there's 3 main reasons to ever need to break the nasal bones electively as part of a rhinoplasty. And those are, if the nose is crooked, you need to re-break them to straighten them. If the nose is too wide and you need to bring it narrow, that makes sense. And then if you take a bump off the bridge of the nose, and I'll show you some examples, what happens is when you take the bump off, there's an opening up top of the nose, and you have to now narrow the nose to bring it back to its more anatomic position. I state here real briefly, usually crooked nose to be fixed with breaking is functional. Usually wide noses to be narrowed and an open roof are more often than not cosmetics. And in this picture here, this just shows a diagram of where the nasal bones are. They're up here. This is cartilage like we described earlier, and this is just analogies of how we can actually break the bones from the inside. I prefer to do them from the outside. The most important thing I want the audience to realize is it doesn't matter which approach is done, so long as the surgeon you go to has experience in that approach, can reproduce it safely, systematically, and give you the best result. I think that's the most important. Personally, I feel that the percutaneous from the outside is safer because you're not disrupting a lot of tissues from the inside as you're going to break the bones, and therefore making the entire structure potentially destabilized. That's my opinion. My mentors who trained me recommended that, and I've been pretty successful with doing that. And so I use that approach. This is just a patient intraoperatively showing that we use a very fine osteotome. It causes a 2 millimeter area where we open, and that's the only opening on the outside. But we keep all of the skin attached. There's no disruption of anything. As you can see, it's already completed. There's no bleeding. And this is post-op about 1 month on the side of the nose. Nothing can be seen. Part 3, our final area, is cosmetic rhinoplasty. This is nasal surgery with the goals to change the appearance of the nose. But remember, it involves function as well. We want to make sure you can still breathe and it looks different to your liking. We have to balance the form, function, and I think the most important part yet again is the patient's aesthetic perception has to be matched. We want to avoid that small pinched nose that cannot breathe. So cosmetic rhinoplasty involves really reshaping the nose. The skin can be detached temporarily to expose everything underlying it, the bone, the cartilage. Sometimes you may use rib or synthetic material or tissue, as some people talk about grafts and so forth, or implants to modify the appearance. Again, we use the closed or open approaches, and the type varies to the patient needs. Repeating the same slide from earlier, because we're dealing with cosmetic rhinoplasty, similar. We can do either no scars on the outside or a scar at the base of the nose. First indication, patient comes to me and says, Dr. Nabili, the bump on my nose, I want it to be removed. That's what's bugging me. It's a cosmetic indication. Very rarely could the actual trauma be the reason for it. Sometimes it can, but more often than not, it's something that falls into the cosmetic realm. And so here's an example of where this area is. And if you recall, as in the earlier slides, we have a bony part of our nose on the dorsum, and we have a cartilage part, but both get removed, the cartilage and the bone. Here's a patient of mine presented with this prominent area that had part of it being bone, part of it being cartilage. When I see you in consultation, we take the photo. Intentionally, we use a shadow. Intentionally. Here's why. Because then we do digital sculpting. And this is computer generated. And the purpose of this is to get an idea of understanding the patient's perception of the aesthetic. We do this preoperatively, we discuss it, and sometimes we modify it. Maybe we don't want the bump completely away. It's what the patient wants and what you want. That's our goal. Sometimes our surgeries are better than the end result, and sometimes the results may not get there. But it's kind of an idea just to get an understanding of where we're headed. So we do this preoperatively. This, I always take a photo right at the time the surgery is done. It's really important before the swelling sets in. And this patient, again, intentionally we keep the shadow because this shadow can't be altered digitally. It's the patient, it's the result. This is her before. This is her before with digital modifications. This is on the operating room table, and this is 1 month after surgery. The tip of the nose. So the bump is one common area, and then there's a tip. The tip of the nose is really important. Oftentimes the tip may be too wide or too upturned, too downturned. We can modify it. I think most often than not, what we end up using are sutures. Simple suturing methods can really solve the problem. But sometimes you need to cut the cartilage, shape the cartilage, add cartilage, remove some cartilage in order to potentially narrow the tip, make the tip wider, bring it out, bring it back in, turn it up, turn it down. Here's another patient of mine as an example. Patient presented, they were not happy with the tip of the nose. To them it felt boxy is the term they used. It looked more bulbous and they wanted a more narrow nose. And so the idea was getting it more of a pyramidal or triangular shape. And so this is just for demonstrating purposes of, you see up here it's flat and it becomes a little bit more boxy compared to where we want to get. So we predicted and we thought about it. We did digital morphing and sculpting, but I draw this just to get an idea of where we're kind of headed. And then with the nasal surgery being an open cosmetic rhinoplasty, we were able to achieve at 3 months a difference in the nasal tip. Let's go to a case example. This is a patient who comes in, needed a, how was our approach, Dr. Nabili? We're going to do an open approach. There's a bump that needs to be removed. Once we remove the bump, the nose is going to look a little wide and we have to narrow it. So we have to do osteotomies, breaking the nose. There's a functional component. But wait, this is cosmetic rhinoplasty. Form and function go hand in hand. The nasal valve is going to be narrow. We need to put a graft there, a spreader graft. The septum, way back to part 1, the septum's deviated too. It's all encompassing. We're changing the shape, balancing form and function. And then we need to modify the tip. It's too wide. So this case that I'm going to demonstrate to you is all-encompassing of all the things we just talked about up until now, from a septoplasty, functional, and now cosmetic. And then last but not least, we also dealt with the turbinates. So the top row is all preoperative. The bottom row is 3 months after surgery. And let's go through this. This is that same steps that I went through. Patient presented. They thought the overall appearance of the nose was a little bit too wide, especially that distal third, the proximal third, the middle third, and the distal third. But overall, we want it to be in balance. They had problems breathing in addition to the appearance. And we can kind of get a notice of that. When we look inside the nose, the septum caudally at the end is a little bit deviated. The turbinate on the inside is a little bit large. But she also said, Dr. Nabili, I don't like this nose being so wide. It looks a little bit too boxy. And then when we did the side view, we tried to understand, do we need to change anything on the side view? Yes. The bump here is minimal, but I don't like it because on the cartilage part as well, it's too rounded. I want it to be a little bit more straight. And that area is called the supratip area as a technical term, but you can hopefully appreciate what we mean by rounded and what we're going to achieve post-op. 3 months later, we did the approach that I just described in all of these steps, drew it out, had all the steps there. We removed the bump, narrowed the nose on both sides with osteotomies with no scars seen. Spreader grafts were placed to keep the internal valves from being too narrow. When you narrow the nose, be careful. We don't want it to be too narrow. We better place some grafts inside so you can still breathe. The tip of the nose, we call these the tip defining points. What is that? When you shine light, it tells it all. The light shines right here. We have one reflex, very rounded wide surface. When you have a nice defined tip, there's 2 light reflexes here, defining our cartilage underneath. The tip itself here became more narrow, and then we achieved what she wanted, which was really taking down subtly this bump and making the super tip area a little bit more refined. So in conclusion, in talking about preparing for a rhinoplasty, the informed consent, the discussion is critical. I actually encourage patients to come more than once, especially if we're dealing with a cosmetic rhinoplasty. And the reason is we go over all the ideas, we understand what's going on, have you go think about it, send you the sculpted images, the digitally modified images, then come back. During this time, I actually believe that all these surgeries I've showed you and the types, at the end of the day, they're elective. And I really want you to be really educated and comfortable with your surgeon and want to proceed without ever having a second guess about that. So what I propose usually is, if you're going to get another opinion, please do. And sometimes I'll offer some names. We have great rhinoplasty surgeons as part of our facial plastic and reconstructive surgery division, Dr. Irene Kim, Dr. Jeffrey Ronsley, and Dr. Gregory Keller. And we also have great rhinoplasty surgeons in our division of plastic surgery here, but also in the community here. We're in Beverly Hills, Los Angeles, Santa Monica, phenomenal surgeons here. So it's important to get an opinion and see what's right for you. Revision. It's important to talk about. What does that mean? You got to do the operation hopefully once the right way, safe, systematic. But even in the best of hands, things can change over time. So it's really important to make sure the nose is structurally sound when you're done, form and function are balanced. But 5 to 30% in the first 2 years or up to decades later, the nose may change. And we know that. So we try to be more conservative now, plan things, don't do a lot of changes that we may have done maybe 20, 30 years ago with a lot of cutting and reshaping where we realize those things change over time. Almost all of the rhinoplasties I do, I always get permission, and I discuss this with the patient, possible ear cartilage. Here's why. Even though you may not have had a septal surgery before, so we expect the septal cartilage to be good, sometimes you go inside the nose and the cartilage may be weak. It may not be ideal. It may fracture easily, and we're trying to reposition the nose, we're trying to improve the breathing, so we always consent for the possibility of using your ear cartilage. People say, oh my gosh, is my ear going to look different? Absolutely not. In this picture here, we're not affecting the cartilage and how your nose appears. We're taking this part of the cartilage, which is the conchal cartilage. The skin's going to be there. No one's going to know. Probably the only way someone would know is if you try to shine a flashlight in your ear, it will be more translucent in the area that the cartilage is removed. And then last but not least, more often than not, if your skin is very thin, we'll consent for what's called a temporalis fascia. It's not a flap, it's a temporalis fascia, and we take it from the side under where the ear incision would be, and it's an extra lining, kind of like a added wallpaper, if you will, if there's irregularities of the actual cartilage when we're done. At the end of the procedure, all of your incisions are closed, a splint is applied. What is a splint? It's like a cast. It's on the outside of the nose. More often than not, we have stabilization or splints inside the nose. It's not packing to block your nose. It's open so you can breathe through it, but it keeps everything secure from the inside and the outside. After surgery, very common, especially if the nose has to be broken, you'll have bruising. We recommend icing. We have a very detailed instruction that we go through with you well before the surgery date. Repeat it the morning of surgery and also afterwards. Headaches and slight bleeding are common. And this is really important. In order to have a safe, systematic approach to rhinoplasty, you really need to have a safe and systematic follow-up. I call you the evening of the surgery. I definitely will call you the day after surgery, and potentially even after that, a day or two. It depends on how you're doing, but that's the minimum. I follow all of my patients the first week and the second week. At the second week mark, we talk about specific massaging maneuvers and taping that I recommend and we'll go over when you come and visit us. I think those are important. For a long-term phenomenal result is to minimize the swelling and try to improve things. And these techniques of taping and massaging are really important. And I follow you for at least 1 year. Usually I say monthly, but most patients after about 3 or 4 months, they may push it to 2 or 3 months. But it's a standing every month because I think it's important for follow-up. And I need you to know that we just didn't do a rhinoplasty so you can say, okay, I'll see you later. No, we want to make sure you're happy. We want to make sure the results as they change over time are followed. And the most important way to do that is to have a close follow-up. Let's go back to our last set of questions, and this is a slide that we saw earlier. So let's see if we answered those. Is this a nose job? Yes, based on the terminology it is. That's a common term, but yes, it is. Is this a septoplasty? Yes, partially, as we talked about. Is this cosmetic? It can be. It can be functional as well. Will it fix my breathing? That's our goal, form and function. Will my nose look straight? Again, yes, if the goals are that you have a deviated nose or a crooked nose and we want to fix that, sure. Will the hump on my nose be gone if I do a rhinoplasty? Yes, and we'd answer that with some patient examples. Do I need anesthesia? At the minimum, local anesthetic if we're going to do a close reduction, some sedation for some of those procedures. And then anesthesia, really you need it for 2 reasons. Because there's some bleeding potentially, and it's close to our mouth, and we want to make sure your airway is safe. And the last question, which I didn't talk about, but I just want to bring up, and I'm happy to discuss it with anyone in the audience today, or again, come and visit us. I don't do a liquid rhinoplasty, but what is it? It's very popular, and the term has become more and more popular. It's a temporary, quick 5 to 15 minute rhinoplasty, which is again molding and shaping with fillers. It's a temporary fix. You have to probably do it every 9 to 12 months. Maybe you can push it to 18 months, but it's really important. It is dangerous without expertise. And the reason I say that is there are some really phenomenal surgeons that can do a phenomenal job with this. And I applaud them. But I just want the audience to know, when you go to consider this, please know that there are serious side effects if it's not done correctly. And the best way you'll know that is to make sure the surgeon's done a lot of it, knows the anatomy, and does a safe, systematic approach to it. I'd like to thank the audience before we go to your questions, and also thank my colleagues with the Division of Facial Plastic and Reconstructive Surgery, my mentors, Dr. Gregory Keller, Dr. Jeffrey Ronsley, and our newly hired colleague, Dr. Irene Kim. All of us do rhinoplasty as part of our facial plastics training. Please contact us. I'd like to thank our department with our new chair, Dr. May St. John, and most importantly, UCLA Health and our UCLA media team. This would not be possible. It's a privilege, truly, and an honor to do this and to have this opportunity. We put our telephone number and email, and if you Google UCLA Facial Plastic Surgery, you'll see this webinar hopefully in 24 to 48 hours. And I just want to bring one more thing up, and that is that this goes on YouTube as well. With UCLA and so forth, I'm not able to respond to the YouTube questions on the YouTube account, but by all means, please email me or contact us and we'll quickly answer your questions within 48 hours or less. And if it's a patient-related question, usually within 12 to 24 hours by just a quick email. Thank you so much for your time. And now we'll go to the audience for some questions. Great, thank you very much. Right, so the first question is actually it's a complicated question to answer because the range is varied. So one of the audience members asked an important question. What is the average cost of a nose job, assuming insurance doesn't cover? That's complicated by 2 ways. I'll tell you why. There's a surgeon's fee, there's an anesthesiologist or anesthesia fee, and there's also a facility, the cost of where it's being done, the supplies being used, and that can vary. So what's really important is I don't like the word shopping around per se, because you really want to first find out who is the best surgeon for the needs you have, number one, and then see what the prices are. But when there's a functional component, oftentimes insurances can cover the functional component as well. So I can't really offer an exact range. We have set prices through UCLA Health, and we're able to really be competitive with that, but really have to balance the competitive price with our level of expertise and making sure that we really provide that level of expertise. So what are the risks with rhinoplasty? I think we kind of went over some of them, but the risks are you can cause a septal perforation. You can cause potentially numbness of the hard palate, based on that earlier slide we talked about. You can potentially cause narrowing of the nose too much, where it does make the breathing worse. And maybe the rhinoplasty can actually make the nose appear worse or than it began. And those are possibilities with rhinoplasty. And so it's really important that we go a conservative, safe approach that really builds on the foundations of the form, does it function well, and at the end of the day, can we get it all to the aesthetic liking of you as the individual? Downtime with rhinoplasty, great question. So the swelling. So everyone says it'll take a year for the end result. That's true, but if we're talking evidence-based, usually within 6 to 12 weeks, at least 70 to 85% of the swelling that's expected to go down resolves. And there's ways to expedite that. And some of that's the massaging and taping techniques that I will instruct you and go over when you meet with me. Bruising, usually about a week, and that depends on the degree of bleeding. When we do that percutaneous approach to the nasal bone breakage from the outside, one of the other reasons I use it is the bruising is minimal, so that's important. Sometimes patients say, well, Dr. Nabili, I heard that you can get tearing from the eyes temporarily. What is that about? What happens with that is you get swelling of the nose, and what we don't realize is the nose and the eyes are close in contact. And our normal tear production naturally drains inside our nose. And temporarily, if the nose gets swollen, blocked from the surgery, you may get tearing. That should go away usually within 24 to 48 hours. When is it a good time to consider rhinoplasty is another question. If we have time, I'd like to answer that as well. I think this is a two-part question. So age groups, teenagers. Let's talk about the youngest age group. So it's really important that the nose, especially the septum and the middle part of the face, has developed as much as it can before we start altering it. So if you're female and you're under the age of 16, we like you to wait. For males, 16 to 18, and some females can go down to 14, but really the longer you wait to really get puberty started, to have the maximal growth of the midface. Now, there are people who have traumas, and it's in a younger group, and we do that. The other comment I'd like to make is, at UCLA, we're very fortunate also in the division of plastic surgery. We have craniofacial experts, and they deal with cleft surgery, and some brilliant colleagues of mine here that are really excellent. And I oftentimes work with them as well if someone's young and we're worried about growth plates, and it's really important. I'm lucky to be in an environment where I can at least call others, and we're a team here really to help you, and this is elective. When is it necessary? That's a tough question, because at the end of the day, it's elective. And so we really want you to be the best of health, even if it's for an elective functional or cosmetic rhinoplasty. You can't be under the weather, even a little bit, because we want you to be the best. Best timing, you don't have a special event coming up. We want to make sure that you're ready for this and you're completely healthy to have an outpatient surgery. And I think the final question is, how often do we need to follow up and do another procedure after rhinoplasty? So I guess in relation to rhinoplasty, the goal is never to have another procedure. We want the procedure to be one, and that should be it. The follow-up, I think maybe I'm on the extreme for closer follow-ups, but I think it's important to at least have that opportunity to see you at least as frequently as permissible and you want for up to a year, if not longer. So I think for that 1 year period where things are changing, you should have some follow-up with your surgeon. If the question was asking about other types of procedures, cosmetic that is, yes, we can actually combine some procedures, facelifts, eye surgery, blepharoplasties, changing the appearance of our eyelids, or brow lifts with the same time as the rhinoplasty. And so that definitely can be done at the same time, and we often do that at the same time. The other scenario is if someone has sinus problems and they need sinus surgery. We can also work with our sinus experts to do a combined surgery in that scenario. So I hope answering these questions have helped, and I hope this was informative. Again, I really appreciate the time you afforded me today, and I look forward to your comments, and thank you again.